Hi guys, my name's Aisha. I'm a dual qualified foundation doctor and I'm also the programme lead for the OMFS Survival Guide. This talk is on VTE prophylaxis, so we're going to go over, the indications for prescribing VTE prophylaxis for patients and a little bit about things to be aware of as well. So the aims and objectives of this are to give you a bit of an overview of the VTE assessment and which patients are particularly at risk of forming clots, to understand which agents we give for VTE prophylaxis and to understand the signs and symptoms of a DVT and a PE. So here's case 1. So we have Kashif, who's a 72-year-old male who's being admitted preoperatively to have a left hemimaxillectomy and reconstructor with a right scapular free flap. So patients due to have this sort of major surgery, we often admit them the day before so we can ensure that all of their pre-op investigations, management, etc., everything's in place. So he is planned to have the left-hand side of his maxilla removed due to a cancer and reconstruction with a scapular free flap. So this is taken from the shoulder. He's going to be planned for surgery tomorrow. So as you can see, he's got quite a complex medical history. He's got angina, type 2 diabetes, peripheral vascular disease and hypertension. So he's got a heart condition and usually anaesthetics would want an echo done beforehand. Have a little look on your system and make sure that this is there. An echo is an ultrasound scan of the heart and kind of gives us a bit of an idea of some of the cardiac function and whether or not he'd be fit for a GA and things. He's on quite a number of medications, as you can see, so you might want to discuss with your registrar if any of these are to be stopped before the operation. The main one that I'm looking at is the Ramipril. We don't often give that on the morning of a general anaesthetic. NKDA stands for known drug allergies. You'll see this written quite a lot. So social history, he's an ex-smoker. He quit 10 years ago. Previously he was smoking 20 a day. He doesn't smoke. He's a retired engineer and he lives at home with his wife and daughter. So even though Kashif is being, admitted electively, we always still look at a patient's observations, even if we're not expecting them to be abnormal. And having a look at these, they're all fine. The blood pressure is a little bit on the higher side, but we know that this patient is on 2 antihypertensive medications as well, so it's probably not all that well controlled. So Kashif had some bloods taken 3 days ago. Hopefully you've already watched all of the blood interpretation talks. So his white cells are a little bit high, 12.9, and these do go up in inflammation, as you would remember. So he does have cancer, and it could be expected that he does have a raised white cell count. But it is also important to ask the patient about signs of a chest or a kidney infection or urinary infection, as he would need treatment for that. His kidney function, having a look at his urea and electrolytes, is a little bit off. You have a look at his GP record and you can see that actually this is normal for him. So remember, patients with diabetes and heart disease are more at risk of kidney disease as well. So it's always important to check the patient's baseline function and make sure that this isn't, a new problem. So every hospital will have a VTE assessment document like this, maybe online, maybe on paper. This is actually an example of one at my own hospital, which is why it's already been filled out. It absolutely must be filled in. It's a really straightforward assessment because you can see here that there's some quite clear criteria that you just tick off the risk factors for the VTE risk or the risk of bleeding. So, you can see consider medical patients at risk of VTE if they are expected to have reduced mobility for 3 days or expected to have ongoing mobility. Surgical patients, have an acute surgical admission or expected to have significant reduction in mobility. That would be, the case for our patient. Have one or more risk factors in table 2, which we'll look at, and are admitted for a surgical procedure with a total anaesthetic and theatre time of more than 90 minutes. Yeah, these free flaps often, this sort of surgery could take 12 to 16 hours. So, he definitely meets that sort of criteria. And then we've got other risk factors for venous thrombosis. So these are all kind of parts of the patient's medical history. So, active malignancy, rheumatological disorders, infections and sepsis, age over 60, and so on. Then there's also an area for risk factors for bleeding. So is the patient actively bleeding? Do they have an acute liver failure? Certain medications that they're taking, if they had a stroke, etc. So having a little look at this, let's have a bit of a think about what are our patients' risk for having a venous thromboembolism. So looking at Kashif, we can see he's got quite a few risks. He's going to have prolonged surgery. He'll definitely have a reduction in mobility afterwards. He has an active malignancy. He's over 60. He does have a chronic venous insufficiency because he's got the peripheral vascular disease. He's going to go to critical care after his surgery, and he has 2 or more comorbidities. The main bleeding risk is that he is undergoing an expected procedure with a high bleeding risk because it's major surgery, so it does have a very high risk of bleeding. However, that bleeding risk outweighs the risk of him getting a DVT or a PE, because all of these patients will have cross-matched blood, which is available for transfusion either during the operation or just after. So we will be giving our patients something to help prevent the VTE. So there's 2 different kind of ways that we can give prophylaxis for VTE. So the first one is mechanical. So TED stockings are the usual compression stockings. Some of you may have worn them if you've been on a long flight. The other thing that we have are floatrons, and these are basically mechanical things, and they're often used either on ICU and in surgery. For patients who are undergoing prolonged surgery, but also, if they have a very high BMI, we don't have stockings that are large enough to fit those patients. Pharmacological prophylaxis, so we will be giving this patient a low molecular weight heparin. These all have different brand names depending on where you work, so you may see dolteparin or enoxaparin. And having a little bit more of a think about other things of pharmacological prophylaxis that we can give to patients. So we may also use something called unfractionated heparin. That's usually given for patients with really bad kidney function, because a low molecular weight heparin can't be given to them because it increases the risk of bleeding quite a lot. May also be given oral anticoagulants, such as like apixaban or rivaroxaban, and these are only actually used after the patient has had a PE or a DVT. But if a patient's already on them for another reason, such as a mechanical heart valve or AF, this will act as their VTE prophylaxis. So we would absolutely not give them any low molecular weight heparin on top. So we're looking at prescribing cash shifts. Dolteparin is the one that I'm going to use as an example here, because that's what we use in the trust that I work in. So we need to know a few things, because prescribing, doses can be adjusted depending on weight and kidney function. So we need to know the patient's past medical history and his drug history. So we know from that he doesn't take any other anticoagulant medications or anything that, would react badly with this dolteparin. So kidney function, we saw the patient's bloods from 2 days ago, and his EGFR was above 70, if you remember. So if you have a look at the BNF and your local guidelines, you can see, again, that kidney function is fine for him to have it. The patient's weight is 87 kilos. So again, if we look at the BNF, that means that we would just give him a dose that is standard of dolteparin, or you'll see people write Fragmin, that's the brand name, of 5,000 units. If he weighed less than 50 kilos, we would give less than that, or if he weighed more than 99 kilos, we'd have to give more than that as well. So it's important to know that a patient's weight can impact on, what dose of the dolteparin or the enoxaparin that they need. And so we've prescribed his VTE prophylaxis, and we're going to move on to case 2. So you are on night shifts now, and you are called to A&E to go and see a 33-year-old female with a left facial cellulitis across the left cheek, spreading around the eye. They tell you that she's had no dental pain or any recent dental treatment, and they don't really know what the source is. So her observations are, so she has saturations of 97% on room air, her respiratory rate is 20, so it's on the higher end of normal. Her heart rate is 101, again on the higher end of normal. Her blood pressure is like 128 over 74, which is fine, and her temperature is 38, which is a bit high. So patients with facial cellulitis, who they are admitted under can be a bit of a point of contention, because some units that I've worked at, they come in under max fax even without a collection or a dental issue. It's just because it's on the face, so they get admitted under max fax. In some other hospitals, the medical team will admit them because if all they need is IV antibiotics, there is no need for them to be admitted under a surgical team. For the sake of this case, we're going to say that we work somewhere where this patient is going to be admitted under us in max fax. So you go and speak to the patient. She denies any bites or any spots that she's picked at, and she's not sure how the cellulitis has come up. Because she has a temperature and a raised heart rate, we do need to admit her for IV antibiotics because the cellulitis is also spreading around the eye. And we need to be thinking, we need to have sepsis in our minds as well. Thinking about what else we'd like to know, so we need to know what her past medical history is and her social history as well, because they haven't told us that. So you go down and you see the patient. She's alert, kind of no immediate concerns. You can see that the cellulitis is spreading across the right cheek and it's periorbital. but her eye examination is completely normal. No dental issues, good oral hygiene, and no signs of any sinusitis that it may have spread from either. She's unsure if she has been bitten because she was actually sat out in the garden yesterday, but you can't see any, kind of obvious bites. She's fit and well, doesn't take any medications, has no known drug allergies. She does smoke 10 a day, drinks about 2 units of alcohol a week. She lives by herself and she works in the admin department for the local university. So as we said, we need to admit this patient for IV antibiotics. So check your local guidelines. Usually we will prescribe flucloxacillin as it's commonly used for skin infections, but it may vary depending on whereabouts you work. So always have a look at that microguide app. We will be prescribing her some pain relief, so we'll give her some paracetamol, and we might also think about giving her some ibuprofen as required, but we need to make sure she's eating because ibuprofen can cause gastric irritation, so I wouldn't give it to any patients that are nil by mouth. And that is the whole point of this talk, but we also need to look at prescribing her some VTE prophylaxis. So, having a look at this, we need to have a little bit of a think about what risks are our patient at. So, she's not expected to have an operation or really be at reduced mobility. She's fit and well. She has really no other risk factors for bleeding. So you decide that she doesn't need any low molecular heparin and she'll be okay with TEDs, and you're just going to tell her to, get up out of bed as much as she can and walk around. So, unfortunately, she's actually not recovered as well with a few shots of IV antibiotics as what we thought. So she's had worsening cellulitis, ophthalmology were involved. She's now on some other antibiotics because she just wasn't improving. So she's now on day 5 of her admission. They have isolated a specific bacteria, and she's now on vancomycin, which is a different type of antibiotic. So this patient, so you're on the ward and it's about 3 o'clock in the afternoon, and the nurse calls you and says this patient's complaining of pain in her leg. Can you come and see her? And she tells you, I took some OBS this morning. So again, not very much information like most of the phone calls that we seem to get. But one of the things you can ask for is, whilst you're going over, you can ask the nurse, please, can you take some observations now, and I'll have a look at them when I come over. So you need to go and see the patient, and even if you're not entirely comfortable doing so, it's really important that you attempt some sort of history for any sort of complaint. We're not expecting any, sort of expert orthopedic limb history or examination, but you can always use a Socrates mnemonic, to take history for anything really. So she tells you that she's had 2 days of worsening pain in her left calf, and it feels quite dull and achy. It started yesterday. She was taking some paracetamol, which was helping, so she didn't tell anyone about it. But now her calf feels swollen as well, and it is quite painful. It's dull pain, it's not radiating, it's not examined her sleep, and she can stand up, she can weight bear. So what's your initial thoughts on this, and what else do we think we need to do? Well, we need to examine the patient. So you have a look at her observations, and saturations are fine, respiratory rate is fine, heart rate is normal, BP is normal, temperature is 37.8. So that is slightly on the higher side, but it has actually come down from before. And remember, we always compare these to how they've been over the last, a few times they've been taken, because we do look at trends. We don't just look at things in isolation. And now you're going to have a quick look at her legs. So like I said, we don't expect, any sort of, really thorough level of a limb exam, but just doing a very basic exam can give us some useful information. So you want to look at both legs and you want to compare them. So you want to have a look for any erythema or swelling, on one or both legs. You want to check the patient can move their feet, their toes, their ankle, like their knees and everything. And you can check for any numbness anywhere as well. So looking at this patient's calves, we can see that one of them is much more red and swollen than the other one. So this patient has a unilateral swollen calf, so we want to be thinking about a deep vein thrombosis. So there is a score that you can calculate. The medicine that we love scoring systems, so this is called a Wells score, and it's a Wells score specific for a DVT. We'll go over the PE one later. We don't expect you to be making any diagnoses off these scores, but any patient with a suspected DVT or PE has to be discussed with a senior, and it's important to know about these scoring systems, because say if you decide to call a med-reg about this, or me, we might ask you to calculate it, and we'd want to know what that score is. So we can see, the parameters of this scoring system is, does she have an active cancer, paralysis or plaster immobilization, bed rest for more than 3 days, localized tenderness across the deep vein system, is her entire leg swollen, calf swelling more than 3 centimeters compared to the other leg, and etc. So if we are calculating our patient's score, so she bed rest for more than 3 days, yes, she's had that. Localized tenderness, yes, she has that. Entire leg swollen, not quite, but her calf is swollen. And we'll say, for the sake of this, she has pitting edema. So that means when you press in, you can still see your fingerprint. And I don't really like the last thing, this alternative diagnosis, at least as likely as deep vein thrombosis. I think it's very subjective. But yeah, so we'll say for this, she scores a 4. So she's scoring to be likely for a DVT. So your registrar comes over from theatre and she comes over to take a history and assesses the patient. And so now it turns out that actually the patient is taking the combined oral contraceptive pill, and this was missed. It wasn't in the original medical history or drug history. So she has said, we need to take a proximal leg ultrasound because we need to see if there is a clot there, and we need to take some baseline bloods. Because this patient has a really high risk of a DVT, the safest thing to do is to prescribe her something to anticoagulate her. And then if the scan comes back negative, we can stop that. So she asks you to prescribe the patient 10 milligrams twice a day of apixaban and order all those other bits and pieces. So this ultrasound Doppler scan is done and it is positive for a DVT. Because we missed that this patient, had a risk factor for DVT and was in hospital for a few days and wasn't on the correct prophylaxis, an incident report is submitted. So this unfortunately does happen, and it's probably more common than what it should be. So it's always really important to remember that patients that are hospitalised have a 10-fold increased risk of DVT or PE. This is significant and it can carry quite a significant comorbidity as well. It is preventable, so we all really need to be vigilant as to the risks when we're admitting our patients and filling out their VTE risk assessment. So having a bit of a think, how could this have been prevented? So one of the main things was that she was on, one of the risk factors is taking the combined oral contraceptive pill, and this was missed when we asked her medical history. So a lot of patients don't actually think of them as medications, so they don't tell you that they're on them. So I always ask specifically about them. I ask them, are you taking any medications that's prescribed by a doctor? Do you buy anything over the counter? If they are of a certain age, I will ask them, are you taking any form of contraception? Or, if they're over a certain age, you would ask them about hormone replacement therapy as well. The other thing that was kind of missed as well is that we should have been reviewing that patient's medications and things daily with a senior, because it may have been expected on admission, she might just stay for a day or two and improve after her IV antibiotics and go home, but she actually had a bit of a prolonged stay, which we weren't expecting. So initially, the pharmacological prophylaxis might not have been indicated because we thought she wasn't staying for too long, plus we didn't know about the contraceptive pill, but actually the stay was prolonged and she ended up, having a risk factor, so she should have been given the low molecular weight heparin as well. And we're now on to the last case. So you're on call and you're on nights now. And one of the nurses from your ward calls about Helen, who's a 58-year-old female who is post-op, day 10. She's had a hemiglossectomy and a right radial forearm free flap, bilateral selective neck dissections with a tracheostomy. And the nurse is asking you to come and see her because she's saying that her chest feels a little bit tight. So, you have a little look at your hand over and you can see she's got COPD, she's got type 2 diabetes and hypertension. So this patient, she's got quite a complex past medical history. Chest tightness could mean anything. So you actually need to go and take a bit more of a history. Has she got chest pain? Is she feeling breathless? We need to know these things. The nurse also hasn't given you any observations. So if these have been done, you need to have a look at them and look at the previous ones as well and have a little look at the trend. So having a little bit of a look from the end of the bed, having a look at Helen, we can see that she is alert and she's able to speak and there's no additional airway noises. So we're able to take a little bit of a history before we need to jump into this A to E assessment just to get a bit more information. So she's speaking in full sentences, but she's a bit breathless. And so she tells you that she's got pain and tightness around the middle of her chest. It's not radiating anywhere, but it started about 3 hours ago. Paracetamol was helping, but now it's getting worse and she feels breathless as well. And her chest pain is worse when she breathes in. And she's never had anything like this before. So now we've got a bit more information. We want to assess this patient, and because she's, complaining of what could potentially be quite a serious issue, we're going to do an A to E assessment. So always from the end of the bed, patient's alert, she's speaking in full sentences, and there's, no sort of airway concerns. You can see that she's got a dressing over where her tracheostomy was removed, and her SATs are 94% on room air. So that's a little bit low. We need to keep that in mind. Breathing wise, you have a listen to her chest. We'll presume now you've been in the job for a while and you're okay with a stethoscope and you can't hear anything abnormal. You can hear air entry everywhere. And her chest is expanding equally. There's no signs of any cyanosis. You have a feel for her trachea and it still feels central, and her respiratory rate is raised at 22. So having a think about, what we look at in the A to E assessment for each component and what interventions and things we might need to do, we can see already she has a breathing problem. So we know that she has COPD, but we need to check what her saturations have been like over some time, because if they were previously, normal and above 96%, the 94 is low and she needs to be given some oxygen. So we need to sit her up if she's not already sat up already, so she can help get, more air into the bases of her lungs. Because she has lower saturations and she's breathing a bit faster, so she's tachypneic, she needs an arterial blood gas, and that needs to be done quite quickly to assess her oxygen, her carbon dioxide and any other sort of metabolic disturbances. And we'll also be able to see that glucose on there. We also need to take a chest x-ray as well to look for any lung pathologies. Have a think about, do we think she's having a COPD exacerbation? One of the giveaways for this is that the patient will sound wheezy because the airways are narrowed and they're obstructed on expiration. In this case, she's not wheezy because we've said that her breath sounds were normal, so an exacerbation is less likely, but it is an important differential to keep in mind. And then moving on to the rest of the A to E assessment, capillary refill time is normal at 3 seconds. Her heart rate is raised at 105, but it's regular, and her blood pressure is 112 over 81. Temperature is 37.4 and is normal. She's not cannulated, she doesn't have a catheter in. She is alert, that ABG comes back and you can see she's got a glucose of 9 and her pupils are equal and reactive. You have a look everywhere else, so her calves are all soft, non-tender, no swellings, her abdomen soft and non-tender. The operative site and the flap and everything is all fine, there's nothing else to see. So if you remember, there were some abnormalities in that circulation assessment. So she's complaining of chest pain, so we must always get an ECG for these patients, even if the pain doesn't quite seem cardiac. She has a background of diabetes, so that puts her at higher risk of an MI, and in addition to having had the risk of major surgery. And in conjunction with that, a lot of patients with diabetes kind of don't experience the same sort of symptoms when they are having a heart attack as some other patients. So we do need to get some bloods. One of the blood tests that we'll order, in addition to the usual ones, is a troponin. So a troponin blood test, this basically is a protein that's released into the blood when the myocardium is damaged. So during an MI, for example, and it's a blood test that we'll take for any patient with chest pain. If it's raised, we'll repeat it 6 hours later and we'll see if it goes up again. And we can, the medics will look at that alongside the ECG to decide whether or not the patient's having an MI. We also need to have an eye on the patient's fluid balance and a urine output as well. So you've done your A to E assessment, and here's the kind of things that we've done. So there was no airway problems. Because her SATs were low, we've put her on high flow oxygen, we've got a chest x-ray, and we've taken an arterial blood gas. We've also got an ECG. She's now cannulated. We've sent off some bloods, and you've also spoken to radiology about taking that urgent chest x-ray as well. So you have spoken to your own registrar who said, please call the medical registrar and tell them everything. So the med-reg comes over and has a look at her ECG and says that there's no kind of ischemic changes, but we'll await this blood test just to make sure she's not having an MI. The arterial blood gas, the only kind of abnormality on it was that, it was the oxygen was a little bit lower, but everything else was fine. Chest x-ray has been done, there's nothing abnormal on that. And the med-reg tells you that she might have a PE, so we need to calculate a well score and we need to consider ordering a CTPA, which is a CT pulmonary angiogram, and that looks at the blood vessels and kind of going around the thorax to see if there's any clots in there. Because she's such high risk, they tell you to, we can't wait for this CTPA, so just start the treatment dose of the dolteparin, which is 12,500 units. She was already on a prophylactic dose, but because we're now thinking that, she has a PE, she needs to be on a treatment dose. So looking at the WELL score for a PE, it's slightly different to the one for a DVT. So you can see if she's had a previous PE or DVT, heart rate more than 100, recent surgery, clinical signs of DVT, hemoptysis or cancer. So for our patient, she is tachycardic. She's got a heart rate more than 100, so she scores a 1.5. She also has had recent surgery or immobilization, so that brings her up to a 3. And she has, I suppose she's had cancer treatment, but it would still come in there. So she's scoring a 4. And if you look at the bottom, patients with a score between 2 to 6 are an intermediate risk. So you might be wondering where on earth we find how we're calculating all of these things. So there's a really handy app called MD Calc. Now, I hope that you won't be calculating WELL scores that frequently, but it has lots of other useful scoring system on there that you might need. So it is just, it's free. It's useful just to have on your phone just in case you ever need to calculate anything. So that is actually the end of this case. Now, again, it's just there to illustrate that we should always be vigilant for our patients. Even, she was on the correct DVT prophylaxis, she still developed PE just because she was high risk. And again, we've, got an A to E assessment that's been put into application there. So you can see, how it's just important to fix the issues that we see. We don't need to actually form a diagnosis, and we always need to be calling for help. So here's some useful learning resources for you. The Show Me app goes through VTE prophylaxis as we have done here. Mind the Bleep has lots of useful articles on very many things, but has some very useful articles on both DVT and PE, and how to assess and what initial investigations you can order. The BNF you'll always need, no matter what you're doing, but especially very useful when you are prescribing that low molecular weight heparin for all of our patients, because you need to know what their weight is and their kidney function. You might need to adjust the dose. The eFace modules on e-learning for health, there is a VTE prophylaxis module on there, very useful to see. And the On-Call in oral maxillofacial surgery just has everything in it, and it's brilliant. So thanks again for joining us. If you have any questions, just drop us an email at omfssurvivalguide@gmail.com. You can also find further information and resources on our website, and don't forget to follow us on Instagram. We'll have flashcards on there, and there'll be further information about our other courses.